This is Dr. Ihab Abdurrahman Ihab Tarawa, consultant of acute care medicine at Soba University Hospital, professor of medicine, University of Khartoum, dean of Sami Institute of Health. We are still doing our session in basic emergency care course. The objectives of this session: explain why to use ABCD approach, discuss safety issues before approaching an acutely ill patient, describe how to assess and manage ABCD components: airway, breathing, circulation, disability, and exposure. ABCD approach, this is stepwise approach, is designed to ensure that life-threatening condition can be quickly identified, treated early, and in order of priority. Identify quickly, treat early, and set priority in management. If a problem is discovered in any of these steps, for example, if there is problem with airway, you have to fix it before you move to breathing. If you discover a problem in breathing, you have to fix it before you go to circulation. So if a problem is discovered in any of these steps, it must be addressed immediately before moving to the next step. The ABCD approach should be performed quickly within the first 5 minutes and repeat it whenever the patient condition deteriorates. So if you fix a problem in breathing and then you move, if there is any change or new development, you go back to the A, then B, then C, then D, then E. The component or the element of the ABCD approach: airway, and whenever you suspect trauma or if there is a real trauma, make sure you stabilize the cervical spine. Check for airway obstruction, and in case of trauma or suspect trauma, you have to immobilize the spine. Breathing plus oxygenation if needed. Ensure that after you make sure the airway is open, make sure airway is moving in and out of the lung and is producing effective ventilation. Then you move to the C, which is the circulation, and make sure there is adequate perfusion, patient is not in shock, and at the same time, if there is bleeding, you have to control that. After that, you move to disability. It can be checked by AVPU, alert, respond to verbal stimuli, respond to painful stimuli, or unconscious. Check the pupil, and remember to check glucose because hypoglycemia can lead to change in mental state. Assess and protect brain and spinal function. And finally, you move to exposure and keep the patient warm, especially trauma patients, they can lose significant temperature. Identify all injuries and environmental threats, avoid hypothermia. So this stepwise approach is designed to ensure that life-threatening conditions are identified and treated early and in the same and in order of priorities. Whenever you discover a problem, you go back, you fix it before you move to the next step. Always remember to look for sign of trauma. Some people, they come with obvious trauma or obvious injury like a motor vehicle accident, or they fell from a height, or they get assault. But some people, they can slip in their floor or trip in their bathroom. So always remember and look for sign of trauma, and whenever you suspect trauma, you need to remember to stabilize the spine, and you need to look for evidence of bleeding, whether revealed or concealed. The first thing, you assess the airway. Make sure the airway is patent. One of the clues that airway is patent is the patient is talking normally. If he's talking normally, then the airway is patent, and move to the other element of the ABCD approach. If not talking normally, is he talking? Does he talk at all? If no, look to see if the chest wall is moving, that is he is moving air in and out, and listen for air movement from the mouth to the nose. If he is talking abnormally or distress, listen for abnormal sounds suggesting obstruction like stridor. Look and listen for fluid in the airway if there is secretion and gargling, and then he might need suction. And look for foreign body swelling around the airway or altered mental state. Check that the patient is able to swallow saliva. If you identify a problem with airway, then if the patient is unconscious and is not breathing, the first thing is to do to open the airway manually. If there is no suspicion of trauma or there is no obvious trauma, you can do what we call head tilt chin lift maneuver. And I have a link for a video demonstrating this uh, in the comment. But when you suspect trauma, you have to protect and immobilize the spine, and then you do the jaw thrust maneuver. If you open the airway, and you might need to maintain the airway open by placing an oropharyngeal or nasopharyngeal airway. We put oropharyngeal airway in comatose or unconscious patient. Nasopharyngeal can be used in conscious patient, but try to avoid it whenever there is suspected fracture base of the skull. When you suspect foreign body in the airway, if it is visible, so carefully you can remove it, and if the patient is able to cough or make noise, you can ask him to cough, encourage cough, and you keep him calm. But if he is choking and not able to cough or make sound, then use the abdominal thrust or back blow, the Heimlich maneuver. And after that, if the patient become unconscious, then you follow the CPR protocol. But if you are able to expel the foreign body, then you put him in the recovery position. And in case there are secretion in the airway, do the airway suctioning, and then you place the patient in the recovery position. And if the patient has a swollen tongue, lips, and they are hive and stridor, and you are suspecting anaphylaxis and airway obstruction due to that, give adrenaline intramuscularly and allow patient to stay in position of comfort. And then if your facility can handle this patient, you keep him and you put him in the appropriate place. If not, you might need to prepare for transfer to another facility. After you assess the airway and manage the airway according to what you find, then you move to breathing. And in assessment, you look, listen, and feel to see if your patient is breathing. Assess if his breathing is very fast, very slow, or very shallow. Look for increased work of breathing if the patient is using the accessory muscle, there is nasal flaring, abnormal chest wall movement, and if there is chest wall indrawing. So this means there is a distress. Listen for abnormal breath sound like wheezes, but remember that those with severe or life-threatening asthma, the wheezes could be absent. Listen for the breath sounds if they are equal on the two sides of the lung. Check for absence of breath sound because if there is dull percussion note and absent breath sound, then you are suspecting large pleural effusion or hemothorax. And if the percussion note is hyperresonant and you have absent breath sound, and at the same time there is hypotension, distended neck vein, and tracheal shift, consider tension pneumothorax. And it's appropriate to check for oxygen saturation. After you assess breathing by look, listen, and feel, if your patient is unconscious with abnormal breathing, just do back valve mask ventilation with oxygen and follow CPR protocol. If not breathing adequately, too slow or too shallow, begin back valve mask ventilation with oxygen. In case you are working in an area where there is no oxygen or oxygen is not immediately available, you can use a back valve mask with the room air and plan for immediate transfer with appropriate airway management. And if patient is breathing fast and hypoxic, give him oxygen. If you discover wheezes during auscultation, then there is airway narrowing, use salbutamol. If there is concern of anaphylaxis because of a swollen lip, tongue, and stridor, use adrenaline. If you are suspecting tension pneumothorax because you see that there is a hyperresonant percussion note and absent breath sound plus congested neck vein and tracheal shift, then you do needle decompression, give oxygen and IV fluid, and plan for chest tube. If you are competent to do it, do it. If you need help, you call for someone to fix it. If concern of pleural effusion or hemothorax, give oxygen and plan for placement of chest tube with person with appropriate competency, and if unknown cause, consider trauma. After you work on A, airway, B, breathing, then you go to circulation. Look, listen, and feel for sign of hypoperfusion and shock, cold or moist extremities, delayed capillary refill, diaphoresis, low blood pressure, tachypnea, tachycardia, or even absent pulse. If you are uh, suspecting bleeding, it could be external or internal, revealed or concealed. Usually bleeding happen in different compartment. The concealed bleeding can happen in the chest, and you can find sign of pleural effusion or hemothorax. In the abdomen, you can see ascites, but sometimes you might need to do a fast scan to look for fluid, or sometimes you do upper quadrant tap. Uh, from the stomach or intestine, when patient is not having hematemesis or melena, the bleeding is still in the bowel, then if you put an NG tube, you can get it, but absence of blood in the NG tube doesn't rule out. It could be in the pelvic, and especially when they are suspecting pelvic fracture, also in the thigh with femoral fracture, and from external wound, and that could be obvious, but also retroperitoneal hematoma could be huge. And in this patient, you can find feature of shock. Also, trauma patient can present with pericardial tamponade, and they present with hypotension, distended neck vein, and muffled heart sounds, and blood pressure would be low. For cardiopulmonary arrest, just follow the protocol for CPR. If poor perfusion, start with giving IV fluid boluses. If external bleeding is apparent and clear, try to apply pressure. If internal bleeding suspected, like pericardial tamponade, uh, refer patient for center where they can do pericardiocentesis. If it is hemothorax, you need to place a chest tube. If unknown cause, remember trauma. In pelvic fracture, you can apply pelvic binder. And also for femoral fracture, you can put a splint in the femur. Step 4, after you fix the airway, after you assess and fix the airway, assess and fix breathing, assess and fix circulation, then you move to disability. And here you assess the level of consciousness. There is two way. You can use the AVPU if the patient is alert, is awake and talking normally, or he just respond to verbal stimuli, or just responding to painful stimuli, or unconscious. And also you can use Glasgow Coma Scale, but usually in the initial primary survey we go with the AVPU, and then later on when we do the secondary survey we do detailed GCS. And always remember hypoglycemia, it can lead to impaired consciousness, and look at the pupil. their size, their reactivity to light, and also check the movement in the limbs if it is symmetrical, and look for sensation. Patient might have stroke, or trauma patient might have hemiplegia, or so on. And look for abnormal movement, convulsive movement. It could be seizure. For if the patient has altered mental state and no trauma, uh, and most of the airway, breathing, and circulation are okay, or you fix them, then you place the patient in the recovery position. If altered mental status, consider checking the glucose, and if it is low, give glucose. If you are suspecting hypoglycemia and you cannot, if you are in a rural hospital and you cannot check the blood glucose, just blindly give them glucose, concentrated glucose. If the patient is convulsing, give benzodiazepine. And in pregnant lady with convulsion, consider eclampsia and give magnesium sulfate. If pupil are small, and the patient have slow or sluggish breathing, consider opiate overdose and consider giving them antidote, which is naloxone. And also, when you are suspecting benzodiazepine overdose, you can give flumazenil. If unequal pupil, consider increased pressure in the brain, they probably raise intracranial pressure. So you have, if there is no suspicion of trauma, you can raise the head of the bed at 30 degree if there is no concern of spinal injury, and plan for early transfer to adequate treatment area, ICU or another facility. If unknown cause of altered mental status, consider trauma and immobilize cervical spine. Step 5, after you assess and manage airway, breathing, circulation, and you look for disability, then you have to expose the patient. Examine the entire body for hidden injury, rashes, bites, or other lesion. You can see a rash for allergic reaction, especially if it is associated with lip and tongue swelling. It could be anaphylaxis, but patient could have just a hive and allergic rash. Some people with sepsis, like meningococcal sepsis, they can have disseminated rash in the body. And if you are suspecting snake bite, immobilize the limb, and if you can take picture of the snake. If possible, you do that without endangering yourself or others. Exposure, consider to remove constricting clothing, especially if the limb is getting swollen, and take out the jewelry or watch. Cover your patient after you do the exposure. Make sure to cover your patient to prevent hypothermia, especially those who are coming with trauma or drowning. Acutely ill patient may be unable to regulate his body temperature. So prevent hypothermia by removing wet clothes and dry the patient thoroughly and keep him covered after you do the exposure and examination. Respect dignity and modesty of your patient. And in case you don't know what is going on, consider trauma, and don't forget log roll and to look at the back. And here you need to stabilize the spine. Thank you, and we will continue in another session to finish the ABCDE approach.